There is a moment most people never talk about. You wake up, you feel it, that low, familiar pressure deep in your belly. The body's quiet signal, the one you have felt 10,000 times before. You go to the bathroom, and nothing happens. You wait, you try, you shift your position. Still nothing. So you tell yourself you will try again in an hour. An hour passes. Same thing. By evening, the pressure has changed. It feels heavier, deeper, not just uncomfortable, wrong. Like something inside you is stuck, and no amount of effort is going to move it. If that sounds familiar, if you are watching this right now and nodding, I need you to hear this clearly. What you are experiencing is not laziness. It is not weakness. And it is most certainly not something to be embarrassed about. It is one of the most common digestive emergencies in adults over 60. And the reason it keeps getting worse in millions of people every single day is simply that no one has ever taken the time to explain what is actually happening inside the body and what to do about it. My name is Dr. Clark. I have spent more than 2 decades working with older adults in clinical practice. And what we are going to talk about today is one of the most urgent, most mishandled, and most silently suffered conditions I encounter. A condition called fecal impaction. Stool that is physically stuck inside the rectum, too hard to pass, too large to move, and growing more serious with every hour it is left untreated. By the time this video ends, you are going to understand exactly what is happening inside your own body. You are going to know the specific symptoms that mislead people into making dangerous mistakes. You are going to have a clear step-by-step plan for what to do, and you are going to understand how to make sure this never happens to you or someone you love again. Stay with me from the beginning, because what I am about to tell you in the next few minutes is something most people only discover after they are already sitting in an emergency room. Let's start exactly where this problem starts, inside the body. Your large intestine, your colon, is roughly 5 feet long. It is a muscular tube with one primary job that most people have never quite thought about. Its job is not simply to move waste out of the body. Its job is to extract moisture from that waste as it travels through. Leaving behind formed stool the body can pass comfortably. Under ideal conditions, this is an almost invisible process. Waste moves, water is absorbed, stool stays soft. The body eliminates. You never think about it. But here is what most people have never been told. Your colon does not have a timer. It does not know to stop pulling water from stool after a certain number of hours. It simply continues doing its job, hour after hour, day after day, regardless of how long that material has been sitting there. And that creates a very specific and very serious problem. Imagine day 1. Stool that should have moved forward has slowed. You feel mildly sluggish. Maybe you haven't been drinking enough water. Maybe a new medication was started. Nothing alarming yet. Day 2. The colon continues its work. Moisture is still being drawn from that mass. It is becoming denser. You might still pass a small amount, enough to feel like things are working. But what comes out is only the outermost layer. The core stays behind. Day 3. That core has now lost a significant portion of its water content. It is beginning to harden. Day 4. Day 5. By day 5 or 6, you are no longer dealing with constipation in the ordinary sense of the word. You are dealing with a large, severely dehydrated, essentially rigid mass of stool that has become wedged inside your rectal cavity. The medical term for this is fecal impaction. Think of it this way. Imagine trying to push a smooth river stone through a short length of garden hose. The hose is designed to carry water. It can stretch a little, it can flex, but a solid stone has no give. It does not compress. And the hose, no matter how hard you squeeze from above, cannot move what physics will not allow. That is the mechanical reality inside your lower digestive tract when this happens. And here is the first thing I need you to truly absorb before we go any further. Straining harder does not move a fecal impaction. Not even a little. In fact, every time you bear down with everything you have against a solid, rigid mass, you are doing something harmful. You are placing dangerous pressure on your cardiovascular system, which matters enormously for anyone over 60 managing blood pressure or heart conditions. You are irritating tissue that is already inflamed. You risk causing hemorrhoids or small tears in the delicate rectal lining. And you are exhausting yourself without moving the blockage a single centimeter. We are going to stop straining. We are going to understand what is actually happening, and we are going to respond correctly. But before we get to the solution, and we will get there in full detail, there is something critically important you need to understand first. Because a fecal impaction disguises itself, it borrows the symptoms of completely different conditions. And if you misread those symptoms, you can make everything dramatically, dangerously worse. The first symptom that misleads people, and this one is genuinely life-saving to understand, is called overflow incontinence. You haven't had a real bowel movement in 4 days. And then, suddenly, liquid. Watery, uncontrolled. You think relief. You think things are finally moving. You think maybe this was a stomach virus after all. It isn't. What is actually happening is this. The solid impaction is blocking the main exit completely. But your intestines haven't stopped producing liquid waste from higher up in the colon. That liquid, unable to move through the main channel, finds the narrow spaces around the outside edges of the blockage. It seeps through, and it exits as watery liquid. This is not diarrhea. This is the blockage weakening around itself. The danger is what happens next. Every year, thousands of people experiencing this symptom reach for an anti-diarrheal medication, something to stop the liquid, something to settle what they assume is an upset stomach. Anti-diarrheal medications work by slowing or stopping the muscle contractions of your intestinal wall. That is precisely the wrong thing to do when there is a mechanical blockage inside you. You are paralyzing the very mechanism your body is using to work around the problem. And you are allowing the impaction to harden further, grow denser, and press deeper against the surrounding tissue. If you are experiencing watery discharge alongside persistent rectal heaviness and an inability to fully empty, please do not take anti-diarrheal medication before speaking with a doctor. That one decision can be the difference between a manageable situation and a genuine emergency. The second symptom that confuses people involves the bladder. And this one arrives completely out of nowhere. You haven't had a bowel movement in days. And then you find yourself struggling to pass urine. You feel the urge. You go to the bathroom, but only a slow, painful trickle comes out, or nothing at all. This seems completely unrelated to your bowels. It is not. Your rectum and your bladder are anatomical neighbors. They share a very confined space inside the pelvis, separated only by a thin, fibrous partition. Under normal circumstances, they coexist without influencing each other. But when the rectum is packed with a large, rigid, dehydrated mass, stretched well beyond its normal capacity, it physically bulges forward into the space the bladder occupies. The pressure can be enough to partially or completely obstruct urinary flow. I have had patients arrive in my clinic convinced they had developed a bladder infection overnight. The real cause was a rectal impaction pressing on the bladder from behind. Once we addressed the impaction, the urinary symptoms resolved completely, without any treatment to the bladder at all. The third misleading symptom is lower back pain. Not sharp, not sudden, just a deep, dull, persistent ache in the lumbar region, often radiating down into the hips or thighs. Most people assume they have slept awkwardly or that their arthritis is flaring. The connection to their bowels never occurs to them. But when a large, rigid mass exerts sustained pressure within the pelvis, that pressure radiates outward along the nerve pathways sharing that confined space. Lower back pain and hip discomfort are both documented manifestations of significant rectal impaction. If you are experiencing unexplained lower back discomfort alongside any bowel irregularity, take that combination seriously. And the fourth symptom, one that specifically concerns older adults, is a change in mental clarity, mild confusion, unusual agitation, a sense of being not quite oneself. This sounds entirely unconnected to bowel function, but the body under significant systemic physical stress, the kind that a large, long-standing impaction creates, can manifest in elderly individuals as disorientation or cognitive changes that from the outside can look like the beginning of something neurological. If someone in your care seems suddenly unlike themselves, and you are uncertain about their bowel status, it is worth asking the question before assuming something neurological has occurred. Now, let me be honest with you about what happens when a fecal impaction is left untreated, not to frighten you, but because you deserve this information delivered clearly. Your intestinal wall is living tissue. It requires oxygen and nutrients from blood every hour of every day. When that wall is chronically overstretched by a rigid mass, the blood supply to the stretched tissue diminishes. The cells lining the rectal wall begin to struggle. The muscle itself starts to fatigue, losing its ability to contract and push forward. As pressure builds, the distension can spread upward, affecting higher and higher sections of the colon. Nausea arrives. Appetite disappears. The abdomen becomes visibly distended. The person feels genuinely unwell. And if the pressure continues, if the wall is stretched beyond the physical limits that human tissue can sustain, the wall can tear. When the intestinal wall perforates, the contents of the digestive tract spill directly into the sterile space of the abdominal cavity. The infection that follows, called peritonitis, moves fast. Without emergency surgical intervention, it is fatal. I share this not to alarm you, but because the path from a few days of constipation to a life-threatening emergency is not as long as most people assume. Early response matters. Correct response matters. And knowing when to act is everything. If you experience any of the following, go to an emergency room immediately. A rigid, board-like abdomen that is tender to the touch. Fever above 101 degrees Fahrenheit. Abdominal pain that is constant and worsening, not crampy and intermittent, but steady and escalating. A complete inability to pass gas. Vomiting that will not stop. Sudden confusion, dizziness, or cold, clammy skin. These are not wait-and-see symptoms. These are go-now symptoms. For the vast majority of people watching this, you are not at that stage. You need the right information delivered clearly at the right moment, and that is exactly what comes next. Before we get to the step-by-step response, I want to spend a few minutes on something that is almost never explained to older adults, and that matters enormously for both treatment and prevention. Fecal impaction does not arrive equally for everyone. It disproportionately affects adults over 65. And understanding why is not about making you feel that something has gone irreversibly wrong. It is about giving you a precise map of where to focus. After the age of 60, four things happen simultaneously inside the digestive system that create the ideal conditions for this problem. The first is that peristalsis, the rhythmic muscular contractions that move waste through the colon, naturally slows with age. The gut, like the rest of the muscular system, loses some of its efficiency over the decades. The second is that thirst sensation diminishes. Many adults over 60 are chronically mildly dehydrated, not through negligence, but because the physiological signal that tells the body it needs water becomes less reliable. You do not feel thirsty, so you do not drink, and your colon has less moisture to work with in keeping stool soft as it moves. The third is medication. Many of the most commonly prescribed drugs for older adults carry constipation as a documented side effect. Opioid pain medications, calcium channel blockers for blood pressure, iron supplements, certain antidepressants, antihistamines, and diuretics. If you are on multiple medications, the combined slowing effect on gut motility can be significant. This does not mean you should stop anything that has been prescribed for you. It means you should ask your doctor directly, could any of my current medications be contributing to constipation? That conversation changes outcomes, and many physicians will not raise it unless you bring it up first. The fourth factor is suppression. Many older adults grew up in an era when bodily functions were deeply private. And so, over years and decades, they learned to suppress their urge to defecate when the timing was inconvenient, when they were away from home, in company, or simply not in the right place. The urge to defecate is created by stretch receptors in the rectal wall. But when that signal is repeatedly ignored, those receptors adapt. They raise their threshold. The urge becomes quieter, less frequent, less urgent. Over years, people who suppressed this reflex habitually find they can go 3, 4, 5 days without feeling any real instinctive pressure. The internal alarm system has been quietly retrained into near silence. Understanding this is not a reason for guilt. It is a reason for a different approach going forward. Now, let us talk about exactly what to do. The very first instruction, and this is the most important single thing I will say in this entire video, is to stop straining. Not because it is merely uncomfortable, but because straining against a solid impaction accomplishes nothing productive and causes several things that are directly harmful. It stresses the heart and cardiovascular system. It injures already inflamed tissue, and it does not move the blockage even a single millimeter. Stop, breathe, and work through this in the correct order. Step 1. Before reaching for anything from a pharmacy, try repositioning your body. Stand up and walk slowly for 2 or 3 minutes. Even gentle movement activates the natural muscular contractions that prolonged sitting and straining suppress. When you return to the bathroom, change the way you sit. Place your feet on a small step stool, a stack of books, or any stable surface that raises your knees above the level of your hips. Lean forward slightly, Elbows resting on your thighs. Breathe slowly. This posture matters far more than most people realize. When you sit on a standard toilet with your thighs at 90 degrees to the floor, a sling-like internal muscle called the puborectalis remains partially contracted, creating a natural kink in the rectal canal. When you elevate your knees, that muscle relaxes. The rectal canal straightens. The path of exit becomes physiologically easier to open. Use gentle, steady breathing pressure, not a forceful push. The goal is simply to open the channel and allow the body to do what it is designed to do. Step 2. Glycerin suppositories. Go to any pharmacy, no prescription needed, and purchase adult glycerin suppositories. Here is the detail most people get wrong. For a true established impaction in an adult, one suppository is frequently insufficient. For a hardened mass that has been forming over several days, many clinicians recommend using 2 to 3 adult-strength suppositories simultaneously. If you are uncertain about what is right for your specific situation, ask the pharmacist before leaving. That is precisely the kind of question they are there to help with. Lie on your left side, not sitting, not on your back. Your left side. This position aligns with the natural anatomical curve of the sigmoid colon and rectum, directing the medication toward the mass rather than away from it. Apply a generous coating of water-based lubricant to each suppository. Do not skip this. The rectal tissue is already irritated. Lubrication makes this both more comfortable and more effective. Insert the suppositories gently and firmly, as deeply as possible, so they sit against or alongside the hardened mass. And now the step that almost everyone gets wrong. Wait. Stay still. Set a timer for 30 to 45 minutes and do not move to the toilet before it goes off. The glycerin needs time to warm to body temperature, melt, spread, and coat the surface of the mass. It draws moisture from the surrounding tissue through osmosis, beginning to soften the outer layer. It stimulates the rectal wall to increase its own natural secretions. All of this takes time. If you stand up after 10 minutes, you will accomplish nothing except wasting the suppositories. The mass will remain exactly where it was. Give your body the time it requires. After 30 to 45 minutes, rise slowly, go to the bathroom, and allow your body to work without forcing. If there is movement, even partial, that is meaningful progress. If there is no movement yet, do not panic. Step 3. Rest, gentle movement, and the second round. Give your body a full hour of rest. Walk gently through your home. Drink a full glass of warm water. Then lie back down on your left side and repeat the suppository process exactly as described. A second round is frequently what finally creates movement. The first application often softens only the outermost layer of the mass. The second round, following rest and movement, reaches further into the core. Be patient. Be methodical. Step 4. If 2 thorough, patient rounds of suppositories have not produced results, the next at-home step is a gentle, over-the-counter enema. A mineral oil enema is particularly well suited for this situation. Mineral oil works as a lubricant, not a stimulant. It coats the impacted mass, softens the outer surface, and reduces friction against the rectal wall without triggering the kind of forceful contractions that harsher preparations produce. It is available at most pharmacies without a prescription. One important caution: sodium phosphate enemas, the most common variety on pharmacy shelves, carry a specific risk for older adults with kidney disease, heart failure, or high blood pressure, as the sodium phosphate is absorbed into the bloodstream and can cause dangerous electrolyte changes. If any of those conditions apply to you, please ask a pharmacist before selecting an enema product. To use: lie on your left side, knees gently drawn toward the chest. Follow the product instructions carefully. Hold the solution for the recommended time and give it 30 to 45 minutes to work before concluding whether it has been effective. If a single enema produces no meaningful result, stop home treatment there. That is the appropriate boundary of what can safely and productively be attempted at home. Step 5. Go to a doctor. Today, not tomorrow. If you have not had a meaningful bowel movement in 3 or more days and the steps above have not produced relief after thorough patient effort, contact your doctor's office or an urgent care clinic today. With fecal impaction, time works directly against you. Every additional hour that stool remains in the rectum without passing, more moisture is extracted, the mass grows harder, and the surrounding tissue endures more stress. At the clinic, a healthcare provider will perform a gentle examination to determine precisely where the blockage is and how significant it has become. If the impaction is within accessible reach, they can manually fragment and remove it safely, a procedure that is uncomfortable briefly, but remarkably effective. Clinical-grade enemas are available in hospital settings that reach far deeper into the colon than anything available over the counter. In the most severe cases, a specialist will perform manual disimpaction under sedation or regional anesthesia, carefully breaking apart and removing the hardened mass with the patient's comfort fully managed throughout. I want to say this clearly. That procedure is serious, it is safe, it is routinely performed, and the patients who describe it to me consistently say the same thing. The relief that follows is profound. Days of pressure, of pain, of quiet fear, gone in moments. Do not let embarrassment delay this decision. Healthcare providers see this regularly. It is a medical situation, not a moral failing, and you deserve care without shame. Once the impaction clears, do not make the mistake that most people make, returning immediately to normal habits as though nothing happened. The 24 hours after an impaction resolves are the most important window for preventing it from happening again. Drink water immediately and consistently. Your tissue is irritated and dehydrated. 6 to 8 glasses across the day, not all at once, but steadily. Begin a gentle soluble fiber supplement that same day. Psyllium husk is among the most well-studied options, and it works by absorbing water and creating soft, bulky stool that moves far more easily through the colon. One absolute rule: always take fiber with a full glass of water. Fiber without adequate hydration can worsen constipation rather than prevent it. Review your medication list with your doctor at the earliest opportunity. Write down everything you take and say directly, "I recently had a fecal impaction, and I would like to know whether any of my medications may have contributed." That conversation changes outcomes. And establish a consistent bathroom routine, beginning the very next morning. Your colon is most active within 15 to 30 minutes of eating breakfast. A natural wave of muscular activity called the gastrocolic reflex, triggered by food entering an empty stomach. Every morning, use that window. Sit down, elevate your feet, lean forward, breathe quietly, and give your body 5 to 10 minutes. Whether or not there is an immediate strong urge, practicing this daily over 2 to 3 weeks retrains the digestive system toward a reliable rhythm. Consistency is the training tool. For the long term, because prevention is always the goal, 4 things make the most meaningful difference. Water, first and always. 6 to 8 glasses a day. A full glass first thing in the morning before anything else. Do not wait until you feel thirsty, because after 60, the thirst reflex is no longer a reliable signal. You need to be deliberate about this. Set a reminder. Keep water visible and accessible throughout the day. Movement, daily. A 20 to 30-minute walk, even slow and comfortable, has been shown to meaningfully accelerate intestinal transit time. Your intestine is muscular tissue that responds directly to the movement of your body. Sitting completely still for long stretches, especially after meals, is one of the most underestimated contributors to constipation in older adults. Fiber, consistently. Whole oats, cooked lentils and beans, apples and pears with the skin, leafy vegetables, ground flaxseed, and prunes, which have specific, well-documented clinical evidence for improving stool frequency. The goal is 25 to 35 grams per day. Most older adults are getting fewer than 15. That gap is where chronic constipation lives. And correct posture every single day. Use a small step stool under your feet on the toilet. Elevate your knees above your hips. Lean forward. It costs nothing to try, and for many older adults, makes everything easier. A brief word about stimulant laxatives, because they are among the most commonly used products for constipation, and the conversation around them is rarely complete. Used occasionally in genuine acute situations, stimulant laxatives are a reasonable tool. The concern arises when they become a daily habit. Your intestinal muscle, like any muscle, responds to repeated external stimulation by reducing its own internal effort. Over time, without the chemical prompt, the gut waits rather than acting on its own. This is called laxative dependency, and it is a real and documented consequence of long-term daily use. If you are currently using stimulant laxatives every day, please do not stop abruptly. Speak with your doctor about transitioning gradually to gentler alternatives, such as osmotic agents or bulk-forming supplements, that support your body's natural function rather than substituting for it. I want to close with something that I think about whenever I make a video like this one. So many people suffer with this condition quietly. For days, for weeks, sometimes for years. Not because there were no solutions, but because no one ever took the time to explain it to them in plain human language. They felt ashamed to mention it. They assumed it was just aging. They tried the wrong things because the right things were never explained. And they waited longer than they should have because they didn't know what the warning signs meant or what to do when they appeared. You are not that person anymore. You understand your body better today than you did when you pressed play. You know what a fecal impaction is, how it forms, and exactly how its symptoms can mislead you. You know the specific steps to take, in order, patiently, correctly. You know when home care is appropriate and when it has reached its limit. And you know what to do in the days and weeks afterward to protect yourself from going through this again. That knowledge is not a small thing. It is the difference between suffering in silence and responding with confidence. It is the difference between a manageable situation and an unnecessary emergency. Take care of yourself. Drink your water, move your body, listen to what your body is trying to tell you, and respond to it early while the response is still simple. That is the most powerful thing any of us can do.